Hey, I'm Jake. I'm a freshman biology major.
And I'm Emmett. I'm also a freshman and I'm majoring in neuroscience.
We're both freshmen in the Global Public Health Scholars Program, and today we're here to discuss an interesting case study along with our guest, Anne Mamish. Would you care to tell us a little bit about yourself and what you do?
Sure. So I'm a recent alumna from the University of Maryland. I went to UMD to get my bachelor's degree in public health science, and then I more recently got my master's in public health and epidemiology. Right now, I'm kind of in between jobs, or in between jobs related to epidemiology. I have a job right now, working in the federal government, but I also hope to go back to school and study epidemiology in the future.
Um, I noted in the email chain you expressed an interest in HIV epidemiology. What sparked that interest?
Yeah, so I've kind of always been interested in infectious disease epidemiology. Unfortunately, at UMD, we didn't really have kind of the electives in order to like really delve into what it means to be an infectious disease epidemiologist. So as for right now, it's mostly just an interest, and I've kind of had that interest since I was an undergrad. But I did so for our master's program, we have a capstone thesis or a capstone project. So for my capstone project, I analyzed the youth risk behavior survey, specifically looking at the relationship between HIV testing and other variables like drug use, alcohol use, sexual behaviors like condom use. And I guess if I could just back up really quickly. So the Youth Risk Behavior Survey is a CDC data set. Uh, it's a cross-sectional serial survey that's done. I think most recently they released 2021 data, but they do it every other year. So my analysis was 2019 data. So that was kind of just looking at the landscape of adolescent or high schoolers among a national data set. But more specifically, mine focused on Maryland. So it was nice to get that kind of touch of what HIV testing looks like in Maryland. But I digress that, I could talk about my for hours.
Yeah, it all sounds very interesting.
Yeah.
All right. Uh, Now, moving on to the main topic for our podcast, we'll be catching up all of our listeners at home with the pre-recorded segment explaining the case study. So we'll cut away to that, and then we'll be right back with the guest segment. Before we even get into the case study, we need to explain why congenital syphilis is such a large issue in Peru. Congenital syphilis has severe consequences if untreated, such as bone deformation, anemia, and brain damage.
Syphilis is also an STI that is spread through unprotected sex. In developing countries such as Peru, where protection isn't common, it isn't common for mothers to have syphilis.
In addition to this, the penicillin needed to combat congenital syphilis is in limited supply, so the healthcare system needs full coverage so they can allocate antibiotics on a case-by-case basis.
This is why efficient syphilis tests are such an important part of Peru's healthcare system. Now, moving on to the case study.
The full name of the case study is Rapid Syphilis Tests as Catalysts for Health System Strengthening, a case study from Peru. Now, that is quite the mouthful, but put simply, that means what is the impact of using quicker and more efficient syphilis tests on a healthcare system?
That is a question we will answer later, but first we must describe the basics of the study. It was conducted in Lima, Peru in 2009 from January to November, with planning beginning in September of 2008.
The intervention itself was based around syphilis tests for mother-to-child transmission in pregnant women. The intervention implemented new point-of-care tests, POCT tests, POCT, and that take 15 to 20 minutes and are much better than the previously used rapid plasma reagent, RPR, tests that took 6 visits and 27 days before results came in. This evidence-based intervention fixed this obvious inefficiency in the system. These tests allow doctors to treat the fetus while it is still in the womb and avoid many disastrous outcomes such as stillbirths, miscarriage, and congenital syphilis, which we mentioned earlier. Syphilis is an STI, so it can be transmitted through blood from mother to child.
The intervention required the training of 604 health providers in how to use the tests, which had some small difficulties in that 44.5% of the workers had blurry vision and required glasses before they were able to view the results of the POCT clearly.
There were some additional difficulties in rolling out the test, for many of the healthcare providers distrusted rapid tests and had doubts about the POCT accuracy. This required more conversations to convince them of their efficacy. Additionally, laboratory workers were concerned about a decrease in their workload, while clinicians were concerned about an increase in their workload. This issue was resolved by clearly dividing different parts of the quality control and testing process so that everyone was satisfied with their amount of work.
Moving on to the implementation of the tests, they were largely successful, creating significant increases in syphilis coverage for antenatal care, ANC, miscarriage services, and delivery and emergency services to a minimum of 91% coverage.
The success of the intervention was clearly noted, for the Peruvian Ministry of Health in 2011 incorporated POCT tests into the nationally published Guidelines for the Prevention of Mother-to-Child Transmission of HIV and Syphilis, and proceeded to order 500,000 POCTs for 2012. Now that our audience is all caught up, we can get into the heart of what we're discussing. Are point-of-care tests going to be a viable and cost-effective testing method when scaled up both in Peru and other developing countries?
And before we get into that, though, Anne, I want to hear your first overall thoughts on the intervention.
Yeah, so I think based off of the manuscript, it was very well designed. I liked how they incorporated all clinicians and not just the people who are doing the test. I think one of the big themes in the author's manuscript was that they initially didn't have a lot of buy-in for the point of care tests because of previous experience with HIV testing. And I think that the clinicians were or not the clinicians, but the physicians specifically were a little bit of a roadblock for the researchers that they were able to overcome, which I think is really relevant and, kind of underscores the fact that it's not just one person who's doing the test. You have to take a more holistic approach on educating clinicians and patients on, new procedures like syphilis point of care testing.
Yeah, that was another thing I noticed is that in the implementation, they went to each group of professionals involved in testing and were like, what are your concerns about the test? It's like, oh, lab techs were concerned about not getting as much work. Then they reassured them, no, you'll be involved in quality testing tests to make sure they all work. And I thought that was something they did a very good job of, reassuring everyone involved. But on relating back to the bigger topic a little bit, that sort of individual reassurance was something that stuck out to me as maybe a challenge to scaling it up, because obviously when you're doing it at the level of hundreds of thousands of tests, you're not going to necessarily have the resources to reassure every single lab tech that, hey, you're still gonna be doing something.
Yeah, agreed.
All right.
Okay. So do you have any thoughts about how the screening process for syphilis could be improved?
So one of the first things that kind of came to mind, it wasn't, and I can't speak to whether the authors actually did this, but something that's very common among HIV research in the United States is something called opt-out testing, where essentially everybody is supposed to get tested for HIV unless you want to opt out of the testing. So that has been shown in the United States and I think in other clinical settings, though I can't speak to the entire body of literature, but it's done a good job at reducing stigma because patients then think oh, everybody gets tested, it's across the board. So it doesn't have that stigma associated with I'm seeking an HIV test. So I wasn't clear if they kind of did that procedure with the pregnant women in Peru, but I think opt-out testing would be another thing that could be implemented to increase testing rates. I know that their testing rates were already pretty high, but that was kind of the major thing that I thought. And then another thing that they didn't explicitly mention, but I would hope that the researchers did this, is that they answered patient questions about syphilis as opposed to just, here's a test for syphilis. So I would hope that they answer the questions and, validate the patient's concerns and things like that. And then finally, on the subject of like the interaction between like the test administrator and patients, I would also want to make sure that patients are getting asked relevant questions about their STI history. I think one of the biggest things, and I'm sure I'll talk about it later, but one of the biggest things that kind of I took away from this study is that the point of care test can't really differentiate between like active syphilis and like latent syphilis because they're testing for antibodies. So it's really relevant information to know if a patient has been treated for syphilis before, because then you know that their test would be positive. Whereas there could be a situation where somebody has latent syphilis and they don't know that they have syphilis and they've never received treatment. So I think that the indications for treatment would be different dependent on like what a patient's STI history is and what their, do they use condoms? Do they use, are they monogamous? Things like that, I think are very important to have in the kind of the picture of the clinical manifestation of like how the patient is presenting to the clinic. But I would hope that the clinicians and the physicians and healthcare staff have already been doing those things. It was just something I noticed wasn't really discussed in the study.
And can you clarify for the audience, what is the difference between latent and active syphilis?
Yeah, so again, I'm not a physician. I have a fairly good understanding of syphilis, but nowhere near the expert level. But so when you're initially infected, you get, and usually it's considered, it's considered an STI. So usually sexually transmitted, but I think if you have forgive me, I can't remember the name, but the kind of spots that you get that are indicative of syphilis, if you have close contact. No, it's
Sores?
Yeah, kind of like sores. I think there's a specific name for it. I can get back to you on that. But I think if you have like direct contact with those, you can also develop syphilis that way. But I think primarily it's an STD. So when you originally get infected, it starts, the kind of chronology is primary, secondary, latent, and then tertiary syphilis. There are different clinical characteristics that define primary and secondary, and tertiary being like more like late stage and more I believe severe. But the big difference is with latent syphilis, you may not really have any symptoms or anything because it's latent. So think like tuberculosis, like latent tuberculosis, you don't have any symptoms really. But if the syphilis is left untreated, it can develop to like worse complications. So you want to make sure that at any stage, if you have syphilis, that it gets treated pretty much. And again, I'm not a physician. I'm going off of my limited information.
Yeah. All right. Still, thank you for the info. All right. Another question. Do you believe there were ethical concerns about how the tests were implemented and used?
So honestly, not really. This was like one little thing that they had said in the manuscript, and I missed it originally, but one thing that's really important when doing studies like this is informed consent. But they did say that they provided, or that patients gave informed consent. I think especially given the history of like malpractice in, developing countries, I think it's really important that researchers do make sure that patients have informed consent. But yeah, they had said that there was informed consent in this manuscript. Other than that, I didn't really see any like glaring non-ethical practices with their protocol.
And to add on to that, what were the ethical strengths of the way the intervention was conducted?
No, I was saying that I didn't see any. I mean, I could give you
like instead of weaknesses where they might have erred, but strengths and where they really did a good job of making sure there were no concerns.
So again, informed consent is a really big one. You cannot, have participants participate, like they wouldn't even be considered willing participants without informed consent, because they need to know what the what's going on, and the fact that they are able to withdraw at any time. I think that's a really big thing in terms of ethicality of studies.
All right, great.
So do you see any way to help address the problems that came up in the planning stage, such as concerns over the accuracy of rapid tests?
Yeah, so I think that the researchers again did a really good job of like the protocol that they came up with, especially in terms of engaging all different kinds of healthcare workers about the process. I do say though, I think maybe even involving them a little bit earlier could have helped. Granted, they did a really good job, but allowing healthcare workers to have an opportunity to engage in the development of these processes, I think would kind of give the healthcare workers that sense of like, they're a central part to the study, and make them feel like they have a larger stake in the success of the program. And I guess like what makes me think of that is because the physicians who initially resisted the testing hadn't originally participated in, or the ones who had resisted with the point of care testing hadn't initially participated in the trainings, but then after they kind of were doing more like drop-in trainings and stuff, they eventually, came around to, the researchers' side about point of care testing.
All right. What do you think were some of the major strengths and weaknesses of the study overall?
So, I guess we'll start with the weaknesses, if that's okay, because I personally think that there are fewer weaknesses than strengths, but I previously discussed this, the point of care test, because they're looking for antibodies, they can't differentiate between the different stages of syphilis, or whether it's like, they had syphilis, were treated, versus they need to be treated for syphilis. So this is kind of like opening a little bit of a can of worms, but I got the impression that if it was positive, the patients would just be given penicillin anyways. And that, I don't know if you guys are familiar with like microbiology and the concept of, antibiotic resistance, but I'm not a physician, but I'm not necessarily sure that would be the best practice to adopt, especially if they're in a country where there may be penicillin shortages, and penicillin is used to treat a lot of different things. And then the other weakness that I gathered from their intervention is that the point of care tests are subjective. I know that they had trained the individuals and made sure that people weren't colorblind, and like they had the appropriate visual acuity to read the test. But I think even then, there can be subjectivity. It's not really clear as, I guess, because, there may be some implicit bias in place too, with like who is, reading the test, and who, their opinions, I guess implicit opinions about the patient. So obviously training helps with that, but I don't think that's necessarily something that you can get away from 100%. But overall, those were really the two major weaknesses of the intervention, and I would argue that it's not really the researchers' fault. They did as much as they could with the point of care test, the nature of the point of care testing. Because when you look at a comparison between, all the benefits of the point of care testing, it being very quick and very inexpensive compared to the way that they previously conducted their testing, and the fact that it has a significantly less burden on these pregnant women who have to go to the doctor, I think 6 times as opposed to 1. I still think that it's necessary to take these weaknesses. I think overall the study did a really good job. And I guess getting into the strengths, I think that one of the things that I had not I don't generally see that often in the literature that I read, is that they had coordination with local and national authorities from the beginning. I thought that was a very good idea, because it, assisted them with the implementation of the point of care tests, and I think also lends to the credibility of their intervention, that, these authorities are down to assist. And I think later on that the Ministry of Health took over too. So I think that was definitely really good to streamline implementation after the researchers left. And then training all the different kinds of healthcare workers and not just physicians, I think was also a strength, because it ultimately led to like more widespread acceptance of the point of care testing among the healthcare workforce. And like I previously said, that slow transition to, overtaking responsibility to the Ministry of Health, I think it really built on their own capacity to manage the program after the study ends. And then I think towards the end of the manuscript, they discussed how their study contributed to like upstream developments of communications with like larger organizations like UNICEF and PAHO. And then the creation of the rapid syphilis test toolkit, I think with the University of London or something, some educational institution. So I think that definitely demonstrates how much of an impact that their study had on, the Peru community and the syphilis community, or the, healthcare workforce dealing with syphilis.
All right, we're running a little long on time, so you've been too good to us. So, well, I think shorter answers, please, for the next couple. All right. Let's go. I think we've got enough. All right. Going back to our central question, do you think this intervention is scalable, and do you think this intervention would work in other developing countries, or did the circumstances unique to Peru and Lima make it work?
So I would say in general, it has the capacity to be scalable. I think one caveat, though, is what works in Peru may not work in other developing countries. One of the tenets of epidemiology is generalizability, and you can't necessarily say that what works for one community or one individual may work for another individual or another community based off of findings of that one community. So one of the things that I thought about is like, what if all of the clinics are in urban populations in a different country? Then even though the women may have access to point of care testing, if they can't get to where they need to go to get the testing, it may not be scalable. So you have to take the differences in different geographic locations into account when considering if something is scalable or not.
All right, great. Now, unfortunately, that's all we have time for, Anne. Do you have any final thoughts about the intervention, the podcast, anything overall?
No, I think it was a really well-designed study. My background being in epidemiology, I like analytical stuff, but I think that, because this study is more qualitative than quantitative, I think that it's definitely very important, very, very important research that they're doing, and I hope to read more of it in the future.
Yeah, I thought it was very, very well done as well.
Very, very interesting. Thank you so much for your time, Anne, and we'll send our audience the summary. Thank you so much. Have a great day.
That was a lot, so let's recap the main points of what we talked about today.
Ethically, we found that the case study did a good job, as it read like they gave informed consent about what the test did to the patients.
In terms of effectiveness, we found that the intervention was very effective overall, and it greatly expanded syphilis coverage in pregnant women.
Finally, in terms of scalability and implementation elsewhere, we concluded that it would likely work, but we truly do not know due to various confounding factors, possibly leading to a unique success in this case.
That's all, folks. What do y'all think about the study? Please comment below or email us your thoughts. Thank you for your time, and goodbye.
Goodbye.